I think we had a long, detailed talk by Gopi yesterday about the spines, and he alluded to all the intricacy of the spine anatomy and the normal benign pathology. I'm just going to embark on the post-operative spine, and maybe I've got some slides of benign pathology as well. I've tried to delete it after Gopi's talk, but I'll try. It's a very difficult and daunting task to look at the spine. It's very complex. The anatomy is very complex, especially if it is being operated on. So, as I told you in my initial talk, that windowing is very important, and what you are looking for, you need to have a very clear vision. Otherwise, you go deep into, and then you don't know how to report and how to come out of this problem. We have been dealing with the imaging, and we have got the Center of Excellence Orthopedic Center, National Orthopedic, which is in Stanmore, and they refer patients. All these patients have been screened with CT, MRI, and all other sorts of imaging, plain films, and it's been inconclusive. The patients have been having continuous pain, and the patient has had surgery for the symptoms, and they have not resolved. So all these are problematic cases. I'm not going to talk about the MR. We have been doing now PET MR with fusion, but that will be a different talk. Again, the conditions affecting the spine is exactly the same as Gopi discussed. It will be degenerative, which the patient has been operated for. There's disc herniation with symptomatology radiating into sciatica, spinal stenosis causing paresthesia and weakness, spondylosis he described, and she shows a lot of images, spondylolisthesis. So basically you need to understand what spondylosis is, listhesis is, and whether it's anti or retro. So whenever you're describing a pathology, you need to relate to an anatomy. If you're talking about spine and like patella, tracking, lateral tracking, so is it lateral or medial? Because it guides the surgeons whether they do a release operation on the lateral side or the medial side. Same with the spine. If it is listhesis, then you need to show whether it's two joints. It's always two joints. So which one is anterior? So if it is L4 over L5, so whether it's going anterior, so you say L4 over L5 anterolisthesis. Or if you want to say, because the L5 is posterior, you say L4 over L5 with L5 retrolisthesis. So the clinicians know what you are talking about. So there is a long list of conditions affecting it. It can be infection, post-operative, tumor, fracture, vascular disorders, and rheumatoid arthritis and ankle spondylitis. Referring criteria again is to identify and localize the site of abnormal uptake and define extent of disease. Planning treatment in post-operative with persistent pain, equivocal abnormal imaging, but they cannot localize the site, and absence of overt structural pathology in presence of high clinical suspicion. Again, doing the SPECT CT, because all these patients are very complex, they have had all these imaging, but if you do a SPECT CT as a one-stop, it improves the sensitivity, specificity, better detection, better localization, shorter time, you get off one-stop service, and the cost implications are less. Again, the same pivotal examination point, looking at the anatomy, because all these are joints and exactly the same pattern follows. So that's why we've been repeating slides again and again, why it is important, because you need to know your anatomy, you need to know what the symptomatology is, you need to know what the finding cause, to use correct modality and discuss to reach conclusions. Discussion with the clinicians and the surgeons are very important. It's a three-dimension imaging. It improves and the localization of the pathology, defines the anatomy. It characterizes the lesion, whether it may be in the body, pedicle, lamina, or facet. Again, the same point: stress, localization, characterization. Then basically, if you're looking at the spine, you're looking at whether it's complete, partial, non-union, of surgical fusion. So it's very important. So you need to window it properly, and then you need to see whether it is fibrous, non-fibrous, calcified, or is solid fusion. If it is solid fusion, then it will not be the pain generator. But if it is fibrous or is soft tissue, then probably that could be the cause. And then if you do the fused imaging, then you will be able to highlight the point of interest, and then that can be targeted by the surgeons. As you know, the variation in spine uptake are caused by normal curvature. So you need to know your normal curvatures. So you have got lordosis in the thoracic, and then you have got slightly convexity with posterior lordosis in the lumbar spine. Again, this is just a normal slide just to show what is the importance of SPECT CT. It's improved sensitivity and specificity, improved diagnostic accuracy, and improved anatomical localization. It's just a comparison of SPECT with the bone scan and fluoride scan. So it just shows the sensitivity and specificity looking at fluoride, which I think most of your bone scans are fluoride scans. So it gives 100% specificity and sensitivity. And if you're just doing SPECT, it's 92 to 82%. So it's quite a variable difference. So again, SPECT CT is superior to both planar and SPECT alone. SPECT correctly characterizes 96% of abnormality observed by planar scintigraphy, and SPECT CT had an impact on the clinical management. So it guides the clinicians and the surgeons what the plan of management would be. It's rapidly evolving from somewhat underutilized because nobody had the evidence-based practice, and now it's been highlighted that this is the future and this can resolve most of the problems. It optimizes the diagnostic capabilities with potential impact on patient management. So it has got a lot of patient management input from the imaging point of view, and has rapid and optimal attenuation correction of the single photon emission data, which I showed in my initial talk. Functional information from SPECT and anatomical information from the CT. When you fuse together, you've got the functionality and the morphology together. This is one of the benign. So we'll talk about the anatomy in detail tomorrow, but it just shows the end plate changes, anterior osteophytosis, probably facetal arthropathy. And then when you fuse it, you know the intensity of uptake, which is acute, which is subacute, and which is chronic. Now, talking about the postoperative spine is very difficult, and if you don't window it, and on this projection, I cannot basically tell you in detail what the interpretations of the images would be, but probably Gopi and I will be having a live cases, so probably that will be the best methodology of explaining and highlighting and addressing the issues, what you need to be looking at and how you should be reporting. But generally, if you're reporting a planar scan, you know there is scoliosis, so you describe the scoliosis, thoracic, lateral on the right hand side and lumbar on the left hand side, and then you know that there is a kyphotic spine, and this is the turning point. It's coming like this and then it bends. So this is the pressure point here and here. So you've got degenerative, most likely degenerative changes. As you go down, it's still fine. Now again, the angle changes here. Then again, this is flex at this point. So this is the most pressure point. So you've got more intense degenerative change. This is just hypothetical, looking at the two planar images. And again, if you look at it, the convexity changes here. You've got this facetal arthropathy, and then probably you've got spinous uptake. So looking at this patient had fixation, rod fixation from here to here. And now you need to look at, this is supposed to be a solid fixation, so there shouldn't be any movement. Any movement between these two fixed points are abnormal, and that could be the pain generator. So now you need to think about it, whether this is pseudoarthrosis or there is an acute fracture or there is something else brewing. So looking at it, there is uptake here. I can't clearly show, I have to have so many slices, but probably we'll have a look later on. It's reflecting properly. So these are the transpedicle screws growing through, and on this it's very difficult to see what's happening. So if I fuse it, so there is this, can you see that line? Because this is kyphotic spine, so they are overlapping and the anatomy is distorted. So that's the facetal arthropathy which is developed between the fixation. So probably that is one of the, if you look at this, that's one vertebra, and the other one is basically the superior is coming here, the inferior is there, so that's the joint there. And that's the important finding. Now if you look at this one, again, that's the facet joint, that's something else, but again you cannot define the anatomy properly. If you fuse it together, you've got again some uptake here, and to me I basically spent a lot of time looking at it, and then I concluded that this is possibly a fracture of the transverse process which is causing uptake. This patient had lumbar fixation, and there is uptake in the L4, L5 region on the planar images. Had an MR, there is fixation, wire fixation to the lumbosacral region. You can't say anything. You see some dark signal, that can be air. You see this dark signal, that's the metal, and you don't know. This is the posterior ligament coming through. That's the black anterior ligament coming through. There's possible small herniation there of the disc, but nothing obvious. If you look at the fused images, it tells you there is something wrong, and that is the cause of the pain. So you see on this, you can't say, you see some air in between the disc, and you've got some metal here, which is probably the fixation of the lumbosacral region, but there's uptake in the superior, inferior end plate and in the disc region. So this is abnormal. Looking at the sagittals, so this is abnormal, so this is pseudoarthrosis. So although they have fixed the joint and supposed to be rigid, but it's not, there is movement which is causing pain. So they need to go back, intervene, and redo the surgery. The patient, I haven't said how many months or years after fixation, so it's probably 2 years, 3 years after fixation, and the patient has had. All these cases are probably more than 2 years. They've gone through the acute phase, because during the acute phase this could be post-inflammatory, so you can't. The CT component of the SPECT CT provides a low radiation dose than diagnostic multi-detector CT. It's about 4 millisieverts. Advantage of utilizing SPECT CT: anatomical accuracy of image registration, effect of CT-based attenuation correction of SPECT, and additional information or diagnosis from CT. So the benefit of this, if you do a SPECT, and then the other thing is, as a imaging physicians, when you have got a data, legally you have to look at everything which is available to you. If you don't, then you are legally liable for missing a lesion. So although this patient had SPECT CT, you have to look at the soft tissue, you have to look at the lung windows, and you have to look at whatever windows are available. The incidental finding of this patient was a lesion, that's the oblique fissure, is plurally based, ill-defined nodule, and this is probably the primary carcinoma of the lung. So it's just an incidental finding. So it's important, is just not do a SPECT CT, look at the spine, what you have done for, and don't look for other things. This is another spine. projected nicely. So this patient had vertebroplasty and spacer device between the disc, probably had reduction in the vertebral heights there, fracture. These are the transpedicle screws growing through. On this, you look at it, basically, if you're looking at the spine, now you need to look at it whether there is fixation, there is any calcification between the joints. So you see this, there is anterior osteophytosis and there is fusion, anterior bridging. So these are the bridging. But there is some air within the disc, the vertebra is gone, so they have put the mesh here. But you don't know why and what's happening. So if you do the functionality of this, there is nothing there, there is no acute process, there is no chronic process, but there is uptake in the facetal joints, which is probably the pain triggering point. Again, stressing on the images, look at the lung windows. If you have done the SPECT, there is a mass in the left lower lobe. If you fuse it, there is no uptake and there is pleural calcification, probably granuloma or pleural plaque, and that's the granuloma there. And the example of pain, patient has been experiencing pain in the left side. They've done the spinal fixation and they don't know what's happening. If you look at the transpedicle, so it should go through the facet, through the pedicle and into the body. You need to look at the position. So sometimes they can migrate, they can be misaligned, they can be introduced in a wrong position. This one, if you look at it, is penetrating through the lateral cortex of the vertebra and is impinging on the pleura. So whenever the patient breathes in and out, it hurts. And suppose it's, I don't know how he escaped pneumothorax there, but you can see this is causing the pain. So that's why it's very important how you window it, and you have to look at all, I've told you, the mediastinal, soft tissue and lung windows. So there is no abnormal uptake on this side, that is no problem with that, but there is uptake here. So if I go back, I haven't got this slide there, but probably that is the fixation, probably that's arthropathy at the facetal joint. These are transpedicle screws. Now looking at it is just gone through, so you need to look at all the slices, so whether there is any lucencies around the screws, and you have to window it properly, otherwise because of beam hardening you will not be able to see it. So there is, if you look at this one, this one, this one relative to each other, these two looks relatively abnormal. There is some air in between, but you still cannot see whether there is lucency or this is artifact. And when you fuse it, you don't see anything on coronals, and then this is the proximal one, and then if you see the axial, there is loosening. So basically you need to marry all the images together and then you conclude what the findings are. Again, severe degenerative disease of the spine, lateral scoliosis, looking at it, degenerative changes, facetal arthropathy, again the same, and this patient had fractures with rod and screw fixation. Again, looking at the and comparing, so you see some lucency there. You don't see much lucency because it depends on the projection of the images, but if you fuse it together, so there is loosening of the screw which is causing pain. So the importance of SPECT CT is immense, and it guides and basically guides the surgeon where to operate and how to manage the patient. This is patient with multiple myeloma, and this patient had probably fracture, complete collapse of this, and had the vertebroplasty for this. and the pain was still there. So as Gopi said yesterday, if you have a spine with multiple fractures, whether you need to find out which one is acute, which one is subacute, and which one is chronic. So if it is acute, then probably that is the pain generator. So it is very difficult. MR can at times tell you whether these are acute changes because of bone edema. And in this patient, you see focal uptake in this region, otherwise the rest of the thing is fine. And doing this lateral segment is hot. So this means they have done kyphoplasty with vertebroplasty, but they haven't put adequate cement in. They have covered the center and the right side, which is fine. There is no movement, but here there is activity and that is causing pain. So they had to go in and put another fragment here to complete the plasty. So it's important. You see, it's difficult on the plane CT or MR to say where the focus is, but with the fused images of using the SPECT CT, it solves the problem. Now, I've got a spectrum of MR. So T1, T2, and T2 fat set. So the fat has been suppressed. So when you suppress the fat, then marrow has got fat. It also suppresses. Anything which remains white is edema. So looking at it, so there are multiple fractures. Again, the importance of what is acute, what is subacute, you don't know. Here is also edema, there is edema here, there is edema, but which one is causing pain? There is marginal edema there, superior end plate. So multi-level fractures. There is no compression of the cord, which could be another cause of the pain. But now, what is the solution? Some of these patients had vertebroplasty, and this one is a compression, superior end plate compression fracture with sclerosis of the superior end plate. This patient was referred and had the SPECT. So this is the acute fracture. The rest are not acute, they are chronic. And this vertebroplasty, which was recent and is showing inflammatory changes, and this is the likely cause of the pain. This one is lumbosacral fixation, end plate changes, listhesis, and they fixed it. And this basically shows intense uptake, and this one basically doing a SPECT shows a fracture of the proximal part of the screw, which is probably causing some movement in this. So it basically highlights what the significance and importance of SPECT CT is as a dual modality, showing the functionality and the morphology together. Thank you.